Buenos días. Les
Good
doy la
morning. I extend a warm welcome to all the people who are joining us in the webinar 132, organized by the Andean Health Organization Hippolyte Unanue Agreement. This cycle of webinars began in May 2020. This year, we're celebrating 50 years of Horas Conju, a very sensitive and significant anniversary due to the difficult times that we're going through. However, as a reference in health in the region, we continue uninterruptedly the joint and articulated actions with the 6 member countries, Bolivia, Colombia, Chile, Ecuador, Peru, and Venezuela, thus fulfilling the goals and objectives to strengthen the health of our people. As a reference in health, we highlight that vaccination against COVID-19 is safe and effective in protecting ourselves and others. The more people who are immunized, the less likely they are to become infected. Make sure you and your families receive the second, third, or fourth dose as appropriate. There is no excuse to comply with the COVID-19 vaccination schedule. The socioeconomic and environmental context in Latin America and the Caribbean is a scenario where hunger, food insecurity, and malnutrition have increased. Policy decisions are required to achieve sustainable, sufficient, inclusive, efficient agri-food systems that generate equal access to a healthy diet for all. Climate change threatens life, health, and well-being. However, we can contribute to its preservation from wherever we are, generating social policies and a sustainable development model. By joining an initiative in defense of the environment, buying local products and plant-based foods. We can use public transport, cycling, or walking, as well as reducing consumption by reusing, repairing, and recycling. It is everyone's duty to restore relationship with nature. It is necessary to recognize the ancestral knowledge of native peoples who have lived in balance with Mother Earth and practice good living. Well, in accordance with the above, today, Thursday, August 11, we open our virtual doors to discuss a topic of great importance for our region, the report of the Lancet Commission on Psychiatry on Violence and Mental Health. We invite you to leave your name, organization, and country from which you are joining us through the comment box of the Facebook Live chat or YouTube Live. In that same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. To access the certificate of attendance of this webinar, as usual, you must fill out a short survey and leave your data in the fixed link found in the Facebook Live or YouTube Live chat. The certificate will be sent to your email in the next days. This webinar will be developed in the usual dynamics. We will start with institutional greeting, then the presentation of our speakers, the active pause, and the space for Q&A. To begin this important day, I give the floor to Dr. Maria Carmen Calle Davila, Executive Secretary of the Horas Conju, who will give the welcome and institutional greeting. Go ahead, Dr. Calle. Are you following Dr. Fisher? Well, violence against women is a serious public health problem and is a line that has been incorporated and strengthened in recent years in the operational plan of the Andean Health Organization on Hippolyte Unanue Agreement, as well as violence against children and adolescents. According to the Lancet report, intimate partner violence is the most common form of violence worldwide. It is considered a gender problem because the majority of victims of intimate partner violence are women. It is estimated that 27% of women and girls over the age of 15 have experienced physical or sexual violence. Domestic violence seriously affects people's mental health, physical violence, verbal or psychological aggression damages a person's self-esteem and often goes unnoticed for a long time due to the victim's fear and silence. In this context, health services become important spaces for the identification of signs of violence, which is why strengthening the skills of health teams to identify them becomes especially relevant. Intimate partner violence contributes significantly to the overall burden of mental health problems. Exposure to child and adult violence increases the likelihood of developing mental health problems, suicidal ideation, or suicide attempts. Children are at high risk for other forms of abuse, and having experienced abuse or being exposed to such violence in childhood significantly increases the risk of experiencing or perpetrating intimate partner violence as adults. Early exposure to stress creates difficulties in coping with stressors throughout life and may increase the risk of mental health and neurodevelopmental problems that contribute to the intergenerational transmission of violence. Associations between mental health problems and intimate partner violence appear to occur throughout life, requiring prevention programs from the school stage that address the factors that foster violence and support for women's secondary and higher education. Early attention is also required, with special importance given to care at the first level of care. Since violence in all its forms is a priority of the works of the Horas Conju, as well as its implications in mental health, the webinar on Summary of the Lancet Commission on Psychiatry on Intimate Partner Violence and Mental Health has been scheduled to highlight the importance of preventing it throughout the life course and its approach to policies, plans, and actions in the ministries of health and other sectors that contribute to the development of children and adolescents. In order to learn about the Lancet Psychiatry Commission report on intimate partner violence and mental health, 3 international experts on the subject have been invited. Helen Fisher from the Institute of Psychiatry, Psychology, and Neuroscience at King's College in London, the UK. Marta Rondon, consultant in psychiatry, nutritional, maternal, and perinatal institute. And Claudia Garcia Moreno, head of unit in the Department of Sexual and Reproductive Health and Research of WHO. With these words, I would like to welcome our distinguished speakers and to everyone who is joining us today. Welcome all. Thank you, Dr. Calle. After the greeting of our Executive Secretary, I will introduce myself. My name is Gloria Lagos Eizaguirre, Manager of Strategic Lines and Coordinator of Andean Committee on Comprehensive Health, Adolescent Health. In this occasion, as Dr. Calle has pointed out, we have 3 experts characterized in the topic that we are going to be dealing. After this preamble, we will begin this event by extending a warm welcome of Professor Helen Fisher. Professor of Developmental Psychopathology at the Institute of Psychiatry, Psychology and Neuroscience, the King's College London in the UK. Her multidisciplinary research program focused on the role of social, psychological, biological, and broader environmental factors in the development, course, and prevention of mental health problems in children, adolescents, young adults. She co-directs the Violence, Abuse, and Mental Health Network at the UK Centre for Research and Innovation, the UKRI, and is also a senior research fellow at the UK Economic and Social Research Council or the Center for Society and Mental Health. Dear Professor Fisher, please, you have the word. Go ahead.
Thank you so much for inviting me today. It's a real pleasure to kick off this event and tell you a bit more about this really important commission. Okay, let me try again. So a real pleasure to give you an overview of the Lancet Psychiatry Commission on Intimate Partner Violence and Mental Health. I'll just provide a bit of an overview of the Commission and some of the key recommendations. So this Lancet Psychiatry Commission on Intimate Partner Violence and Mental Health was convened to consider progress in reducing the prevalence of intimate partner violence and associated mental health harms, and to establish a roadmap for strengthening responses across mental health services, research, and policy. It was instigated by the Violence, Abuse and Mental Health Network, an interdisciplinary research network funded by UK Research and Innovation that aims to understand, prevent, and reduce the impact of domestic abuse and violence on mental health. This commission brought together individuals from a variety of backgrounds with interests or expertise in intimate partner violence and mental health, some with lived experience of these issues, others with expertise from the work that they do. This commission presents a synthesis of evidence, academic, clinical, and experiential, which was considered important by the authors, who are a group of international experts from Australia, Canada, India, Malaysia, Peru, South Africa, Switzerland, the UK, and the USA. In putting together this commission, we decided to focus mainly on the changes needed to address intimate partner violence within secondary mental health services. Although mental health care is delivered predominantly through primary care globally, the relationship between intimate partner violence and severe mental health problems and how best to address such violence within secondary mental health care have been neglected. And thus we felt this was an important focus for the Commission. This inevitably means that some of the recommendations set out in the Commission may be more relevant for countries that have widespread provision of mental health services. But we believe there is much in the Commission that has relevance for practitioners, policymakers, and non-governmental organisations across the globe. And we hope the recommendations presented will act as a starting point for people to consider how best to prevent and tackle intimate partner violence within their own contexts in order to break the cycle of intergenerational transmission of trauma and reduce the global burden of mental health problems. So intimate partner violence refers to any behavior perpetrated against a current or former intimate partner that causes physical, psychological, or sexual harm, including physical violence, emotional abuse, sexual violence, and controlling and coercive behaviors. Intimate partner violence is the most common form of violence worldwide, but it is highest in low-income countries. As we've already heard, although women can be violent towards their partners of any gender, intimate partner violence is mostly committed by men against women. Globally, an estimated 27% of women and girls aged 15 years or older have experienced physical or sexual IPV. But high rates of IPV are also experienced by other groups, including sexual and gender minorities, people with disabilities, migrants, and people from marginalized ethnic or indigenous groups. Data also show that exposure to intimate partner violence continues throughout the life course. Although physical violence tends to decline with age, rates of non-physical abuse remain stable across all age groups. Therefore, IPV is a public health crisis. It has been associated with physical, mental, sexual, and reproductive health problems and death due to homicide and suicide. So the relationship between IPV and mental health is complex. Exposure to IPV in childhood or adulthood increases the likelihood of developing a range of mental health problems, suicidal ideation, and attempting suicide. The presence of mental health problems also makes individuals more vulnerable to experiencing IPV. Previous research has reported that 2/3 of women and 1/3 of men who are in contact with mental health services have experienced domestic abuse, figures that are considerably higher than found in the general population. Children who are exposed to IPV are at high risk of additional forms of abuse and neglect. And experiencing abuse or being exposed to IPV in childhood greatly increases the risk of both experiencing and perpetrating IPV as an adult. People diagnosed with mental health problems are more likely to commit IPV than those without mental health diagnoses, although absolute rates of IPV perpetration are low. And people with mental health problems are more likely to experience than to commit IPV. This relationship seems to be partly mediated through substance misuse, with an increased incidence of violence when mental health problems and substance misuse co-occur. Research in this area is controversial. Mechanisms still need to be elucidated, and there are concerns about the potentially stigmatizing consequences of examining the role of mental health problems in the perpetration of IPV, as well as concerns that diagnoses such as borderline personality disorder pathologize women's responses to violence and oppression. However, associations between mental health problems and experiencing or perpetrating IPV appear to occur across the life course and relate to both the onset and course of mental health problems. Reducing IPV is very likely to improve mental health outcomes, irrespective of whether exposure occurs directly in adulthood, indirectly in childhood, or both. Although IPV is endemic, it is not inevitable. Evidence points to several targets for prevention and intervention in individuals, families, communities, and societies. Some are stage-specific, such as parenting programs to reduce childhood abuse and neglect, or school-based programs to address violence-supported norms and behaviours. Others span several stages, or are relevant across the life course, such as the prevention and treatment of substance misuse and support for secondary and higher education for women. So let me finish with the key recommendations. So the key recommendations for mental health services and practitioners are as follows. Firstly, services need to address IPV using gender-sensitive and trauma-informed approaches that are co-produced with survivors. They need to work closely with third sector organizations and ensure that all practitioners receive appropriate training. Practitioners should ask all service users, especially women and gender sexual minorities, about experiences of violence, including IPV, during mental health assessments. Assessments should be done in private by trained practitioners using the World Health Organization's LIVES principles for first-line response and working within a clear referral framework. Children and adolescents with emotional and behavioral problems should be assessed for exposure to IPV and be offered specific interventions alone or with their caregivers as required. The key messages for commissioners of services at national and local levels are particularly that more specialist services are needed to tackle intimate partner violence, and these need to work closely with mental health services. Commissioning bodies and local authorities need to ensure that they commission services that are gender sensitive, trauma informed, and most importantly, co-produced with survivors of intimate partner violence. There also needs to be adequate funding and provision for healthcare staff to be trained in trauma-informed approaches, and specifically in the appropriate ways to assess and respond to IPV among individuals who come into contact with mental health services. Our key recommendations for researchers are that they should include IPV as a potential moderator of treatment response in intervention studies and ensure IPV is measured in new population-based cohorts. They should also improve coordination and cooperation across sectors regarding both data collection for IPV and core indicators and outcomes to assess interventions to reduce IPV. And these need to reflect the priorities of survivors. Therefore, in conclusion, our ambition is to prevent IPV, and in doing so, decrease the prevalence of mental health problems in society. With scientific effort, coordinated action, and political will, there is not only opportunity for change, but an imperative to do so. So I'll finish there, and I just wanted to thank everybody involved in this commission, which, as you can see on the screen, is a large number of people from across the world. And also wanted to thank all of the survivors who really generously provided their voices to the commission. We also thank all the people who funded this work, the Lancet Psychiatry for producing this commission, and of course to the organisers for providing this opportunity to share this commission, really important commission, with you. Thank
you. Thank you so much, Dr. Fisher, for your wonderful lecture. We thank you for your intervention, where you pointed out that your study was aimed to evaluate the existing evidence on IPV and the relationship with mental health from different perspectives, and to offer some recommendations. You pointed out that despite the IPV considered to be a gender issue and affects mainly women and children, we should not forget that violence also affects the sexual minorities, gender minorities, people with disabilities, migrants, original peoples, and populations that are exposed due to their higher vulnerability. It is extremely important to prevent and do the intervention in the individual, family, and societies, as you mentioned, and this prevention and this intervention should be given throughout the cycle of life. There are programs for small children during the school age, but also to approach the standards and that support violence, and also to prevent the substance abuse and support on secondary or superior education for women. Among the recommendations that you pointed out, we highlighted that it is important to approach violence by using gender-sensitive approaches that co-produce with survivors. All professionals should get training so they don't miss the identification of symptoms in their services. Children and adolescents with emotional and behavioral problems also should be evaluated to identify if they are being victims of violence inside the family. We need more specialized services to approach this condition, so we require to train the professionals in health, but also from other services in order to be alert to any symptom or sign that they could present. And of course, to do more research on this topic, because this is a wide topic and we require more research. Thank you so much. Very interesting research, and thank you for sharing it with us. Professor Fisher, we thank you, and please remain in the room, because at the end we will have a Q&A session to the questions that are already arriving from the participants. Now, we would like to welcome Dr. Marta Rondon, who is a psychiatrist with undergraduate studies in medicine at the Universidad Nacional de San Agustín, Arequipa, with a degree in specialist in psychiatry from the Universidad Peruana Cayetano Heredia, with a master's degree in mental health policies and services from the University Nova de Lisboa, Portugal. Consultant in psychiatry of the Perinatal Maternal and National Institute, formerly assistant professor at the Universidad Peruana Cayetano Heredia, currently visiting professor at the Universidad Nacional Federico Villarreal, Universidad Particular San Martín de Porres, and at the Universidad Nacional Mayor de San Marcos. Dr. Rodon is a former vice dean of the Peruvian Medical Association. 2008-2009, she received a Diploma of Merit from that institution in 2007 and the Diploma and Medal of Extraordinary Merit in October 2015. She is a past president of the International Women's Mental Health Association and honorary member of the World Psychiatry Association since 2005. Past president of the Peruvian Psychiatric Association and member of the Committee of Experts in Sexual and Reproductive Health of the Ministry of Health, Peru. Researcher in women's mental health, gender-based violence, emotional consequences of induced abortion, rights of women and people with psychiatric disorders, and mental health services. Welcome, Dr. Rondon. It's a pleasure to have you with us. You have the floor. Thank you very much for the invitation. I would like to thank Dr. Mari Carmen Calle Davila, who is always gives us a space. Speaking of a very important topic, I am going to talk specifically on the clinical and health policy implications of the Commission for Latin America and the Caribbean. I should say that I have no conflict of interest or disclosures, except that I'm a member of the Lancet Psychiatry Commission on Domestic Violence and Mental Health. I will talk about the context of Latin America and the Caribbean in terms of violence. The multi-causality of violence allows us to have moments to intervene, and some recommendations that are very relevant to our continent, and then arrive to a few conclusions. Latin America and the Caribbean are areas where there is a lot of violence. The last data from WHO of the global and regional estimates of violence show us that the lifetime prevalence in the world of women over the age of 15, excuse me, around 26%, and women of reproductive age is somewhat higher. Women in union over the age of 15 have a prevalence, a 12-month prevalence or annual prevalence of 13%, and women of reproductive age, a 10%, 12-month prevalence. But if we look at the map, we will realize that the average hide, and what they hide is that in countries, as you can see, from the US, but in particular Mexico, Central America, and downwards, we have very high rates of violence against women. You see Bolivia with more than 40%, Peru between 35 and 39%. So we see two islands, which are Venezuela and Paraguay and Uruguay, where the rates are lower. But in general, we can state that in Latin America, violence against women and children is a significant problem, more important than in other regions of the world. In the Commission, we drafted this graph that you're going to find in the report, where we talk about the different points of risk during the life cycle and the interventions that we could use to decrease the risk and fix the situation. And we have also differentiated which interventions are in terms of policies and which ones are in charge of the health and mental health services. So now I will translate some of these recommendations to the Latin American context. The first recommendation at a macro level is, of course, do something about the inequality with the gender equity. We know that the land for women is not leveled. Inequality is deeply rooted in our conception of the world. It is the natural thing to do and is maintained by social norms implemented at all levels. and they bring expectations of males regarding women's behavior. And when that's not crystallized, this provokes violence. And there are women that have read, have grown, have developed, and they challenge those machista standards, and that also generates violence against them. We also have to implement laws for the protection of women and girls from violence. In Latin America and the Caribbean, that's not the case. Our laws have improved. We have violence against family, but we didn't speak about women. But now these are better laws. However, there's a lack of budget, and there are difficulties in training of those who have to implement them. So they don't even know about it, and there are failures in their intersectoral coordination and a lack of accountability, no transparency. So these laws, in order to work, they need to have a budget and training. We also need to have access to specialized services for women affected by violence. As Dr. Fisher mentioned, we in the Commission are concerned because there are no secondary services. In many parts of the world, they have recognition at the person level, but once that we found women who are deeply affected by violence, what do? We need specialized services. For example, in Mexico, they have the Spotlight initiative that strengthens remote care services for women and girls victims of violence, and these are specialized. There is a gap, a significant gap in health services and healthcare. When we report to the institutions about the available services, there's a lack of many of those, and many services perhaps don't even exist. There we need to improve in terms of the services that we have available, the staff that's trained, and the misinformation with regards to the violence-based care, because we can say that the service exists, but who is that service taking care of, and how is the staff being trained? That's something that we need to do a lot of work in our continent. We also need to measure violence more accurately. If we don't have a consideration of that type, frequency, severity, context, and consequences on the person who experienced the violence, we end up that men and women attack each other in a similar way, and there's a symmetric situation, which is not true, because many times the context, the severity, and the consequences are completely different for male compared to women. Another thing is that we still do not measure verbal violence, coercion, or harassment as compared to the physical violence that from the clinical point of view, we know is frequent. That is not being measured in our research. Another issue that we have with the evaluation is the estimation of the risk of feminicide. The measures that are currently used have not yet reached acceptable level of validity and reliability. So their researchers have to work on that. And on the other hand, those of us who work in the clinical area and decision making, we need to incorporate scales to measure risk with higher validity and reliability, specifically in the forensic setting, to improve integrity and objectivity. Another topic that hasn't been adequately approached is the estimation of mental disorders of perpetrators and survivors to violence. We're just using scales, and we know that that has a limited validity, and we need to make it's better to have a clinical diagnosis, be more certain of how we're going to approach that person. Finally, we need to create a culture of well-being among us. We need to forget both of romanticize who offer care. We have a concept of citizenship that is essential in the labor market, and women also want to be citizens. But our participation in labor market is difficult because of the efforts of care. And so our situation is diminished compared to men, and therefore we are more vulnerable to violence and to and don't respect our rights. If we can spread the household and care that doesn't only rely on women but also on men, we're going to have a better labor market participation and the citizenship by recognition for women, and we're going to have the participation and independence of women. Therefore, we need to value the care that we do, value the caretaker, realize that to take care and be employed are two sides of the same coin, have universal access to health, and to get rid of the structured labor standards from the masculine perspective. And if we can change that, we're going to decrease the violence against women. That's from the macro point of view. From the components of the multisectorial response, we need to improve social benefits. We need to guarantee food security for women or in pregnant women and protected against violence, improve the interventions in support of the family in the first years of life, not only with food or interventions from the health personnel that support the growth and development, including interventions to improve the link, which will be a way to decrease the intergenerational transmission of violence. And of course, we need sexual education, which includes education about the interpersonal relations and the promotion of less rigid positive gender roles and gender equity. And that has to occur in the educational environment from the first years of life. From health and mental health services, we need to improve treatment of mental disorders of parents in order to improve their limit the exposure to stress of children and therefore limit the possibility that they will be perpetrators. We also need to recognize and treat the substance and alcohol abuse disorders. And we need to remember that 12% of the violence is perpetrated by people with mental diseases or alcohol or substance disorders. So we treat that, there's going to be a decrease in violence. And the other thing we need to do is to provide adequate treatment to neurodevelopmental disorders and mental disorders for children to decrease bullying and difficulties in their schooling. We also need to guarantee access to sexual and reproductive health services of quality, because we know, and it has been published by others, that the primary prevention in mental health may be done through good sexual and reproductive health services during the perinatal period, a period of great sensitivity where we can carry out interventions to reduce the risk factors in periods of increased sensitivity, such as adolescence. For example, there we can intervene with primary prevention of mental disorders and substance abuse disorders that itself are going to generate a decrease in violence. And we have to transform our services to address violence. Professor Fisher has already told us, focus on female survivor with gender perspective and respectful of human rights. That is easy to say, but we know that that is something that occurs in our context. The services should be informed on trauma. They must understand the dynamic of violence and should be focused on the person's experience in order to prevent to have poor realistics of our effort. Women want to control their control action and act in favor of themselves, to recognize their experience and to experience an emotional connection with the health provider. We also have to remember that the World Health Organization has built this ANIMA acronym that says that women affected with violence, we need to hear them, do not judge, ask about their safety, improve the risk, and support them. So this is to put them in contact with the institutions that they require. These are the guiding principles of integrated trauma care that should provide security, trust, and transparency. Should be a service that is collaborative and mutual, should provide empowerment, voice, and choice, should take into consideration the cultural, historical, and gender issues, and should be based on peer support, so women feel that they are really understood, safe, and can trust who is providing the service or the care, and they feel that they're being involved in their own improvement. COVID has highlighted the inequality in the distribution of roles. There's a significant increase in violence against girls and women. So we think this is due to the sanitary measures, the closure of services, the increase of substance consumption, and an increase in pensions in home level. But the lessons that COVID has given us that we need to the significant transformation of the relationship inside the household. So care is not only the responsibility of women, and also that we cannot afford to close the services for women or health services. In conclusion, I want to say that the most frequent form of violence is the violence against women that affects girls, adolescents, and women with unfavorable consequences to their health. But the Commission has focused mainly on specialized services at the second level, where the recommendations that we have to provide is that we need to know the evidence of the relationship between violence and mental disorder. We need to improve the assessment and measurement of violence. We need to transform mental health services to serve women affected by violence with specialized services that would allow us to approach the most complex cases, remembering that not all women are going to need mental health services, but if they do, they should be adequate. And finally, remember that it has been established that the greater the inequity in a country, the greater the violence against women. We need to reduce inequity and improve the social response. Latin America is a continent with more inequity, and we need to change that in order to decrease our numbers of violence against women, children, and adolescents. And the response has to be a response not only from the health point of view, but from the all type of services and the society. Thank you very much for listening. We thank the intervention of Dr. Marta Rondon. She highlighted that gender inequality is rooted in the world, and we maintain social standards implemented at every level. She also indicated that despite all countries have laws that have gradually improved, they're still had not been fully implemented for several reasons due to a lack of valid intersectorial coordination. Therefore, we require to implement these laws to protect women and adolescents against violence and to have trained staff and services to offer quality service. We need to measure violence with more accuracy, do a more precise diagnosis in mental health. We need mental health services to treat and care women affected from violence. We're required to construct the concept of citizenship that includes women and takes consider their needs and protection and be heard. We need to decrease inequality and to improve social response, not only from the health point of view, because the higher the inequity, more violence against women, as Dr. pointed out. For all of this, we require budget. As we say in our organization, without a budget, there's no right. Thank you so much, Dr. Rondon. We thank you, and now we invite you to stay in the room to start the Q&A session. We continue with the agenda. We give a warm welcome to Dr. Claudia Garcia Moreno, who is head of the unit in the Department of Sexual and Reproductive Health and Research at the World Health Organization, working on adolescent health, violence against women, and harmful practices. She has over 30 years of experience in public health and global health policy, with a focus on women's health, sexual and reproductive health, and HIV/AIDS. He has led the WHO's work on gender and women's health and violence against women, including coordinating the WHO multi-country study on women's health and domestic violence, and leading the first global and regional estimates on intimate partner violence and sexual violence against women. Dr. Garcia Moreno is a founder, past president, and now serves on the Leadership Council of the Sexual Violence Research Initiative and chair the Independent Advisory Board of the What Works to Prevent Violence Against Women and Girls Research. She is a physician from Mexico with a master's in community medicine in the London School of Hygiene and Tropical Medicine in London. Welcome, dear Dr. Garcia Moreno. You have the floor. Thank you, Gloria, and thank you, Dr. Rondon and Dr. Fisher. The advantage of being last is that many of the things already been said. We had two excellent presentations with a lot of detail. So I will just going to comment some things and repeat and to put it in the context of the work that WHO is doing. First, I would like to share that participating in the Lancet Commission on Intimate Partner Violence and Mental Health was an honor and an interesting experience. It's been a process of a 2-year process of sharing perspectives that are not always the same, and to listen and to come with a report that is clear and hopefully can influence and provoke changes in the policies, especially in the services in practicing mental health in benefit, especially of women survivors of intimate partner violence. The World Health Organization committed and has been working for more than 25 years on the prevention and a response to violence against women. Certainly, there have been important changes in these 25 years, including the most important one that it has switched from being a marginalized topic that received very little attention to be an issue that was highly visible. And here I would like to share that in May of 2016, the World Health Assembly, which is the annual meeting of the Ministry of Health of 194 member states, approved and adopted global action plan to strengthen the response to the health systems to interpersonal violence, specifically in violence against children and women. And I say historic because it was difficult to come to an agreement. It would seem obvious that all the Ministry of Health will support a global action to strengthen the role of the health system. But there are different opinions, many things around the topic that Dr. Rondon mentioned of sexual and reproductive health that is always complicated, and the gender equality. But well, the positive result is that this program was adopted and was unanimously adopted by the 194 member countries. The action plan emphasizes four strategic access, which you can see there, but it's mainly to strengthen the access to health services and training health practitioners to respond, as we've heard, focus on the needs of survivors and also to strengthen the evidence-based programs and to improve the available evidence and information. Now, in terms of the information and available evidence, one of the access of the efforts of WHO for a long time. This effort includes the first multi-country study of violence against women and health that was conceived after the Beijing conference at the end of the 90s. And Peru was one of the participated countries in this study. And the report published in 2005 was the first call of attention to the prevalence and the magnitude of the problem and the impact that had on women's health, the domestic or partner violence. And at the country level, the data were useful to generate a discussion on a topic that many times was not considered, and also to start to understand the differences, for example, between the urban areas of Lima and the rural areas of Cusco, which were the two sites where the study was carried out, and to understand the importance of the different factors that increase the risk, as we mentioned, alcohol, growing on a family that experience violence, or the factors that can protect, like secondary education, the access to economic resources. That was one of the first studies in bringing scientifically collected data that validated the problem that for a long time has been recognized and highlighted by women's organizations. We continue working on estimating the global, regional, and national statistics that were already mentioned. So I will not go into much detail, just to highlight that at the global level, nearly 1 in 3 women have been subject of one or both of these forms of violence, at least on their lifetime. And most of this violence is intimate partners. Dr. Rondon mentioned the global prevalence. This is just to show that the prevalence persists throughout life, but also highlight that it starts early in life. Almost 1 in 4 ever married or partner adolescent girls have already been subject to physical and or sexual violence from an intimate partner. And most of young women between 15 and 34 years, talking about 60%, experience violence, recent or present in the last or past 12 months. So this is a problem that persists throughout the life cycle, but I would like to highlight that it starts very early. So adolescents have to be addressed because this is a decisive moment in their relationship, in their health, etc. I'm not going to go in depth because this has already been mentioned, just to highlight that there's significant difference between the regions and is a global persistent problem and permanent in the life of many women. Now, at the same time that WHO has given attention to this issue, it's also working to increase the awareness of mental health. There's a slogan, there's no mental health, there's no health without mental health. In June of this year, this World Report was published, the transforming mental health for everyone. Here, they recognize that the needs in terms of mental health are considerable, but the response are not enough and inappropriate. And the report also emphasizes the stigmatization and social exclusion that result when there are no environments that protect and support those who need mental health services. And we know that this stigmatization and social exclusion doubles when we have intimate partner violence. From all these women that are suffering intimate partner violence, we know that many of them go to see health services, although not necessarily reveal the violence. And these meetings with the health system, with health providers, are opportunities for an early detection and intervention that may contribute to reduce the impact on health of women and their children, reduce the recurrence of violence, reduce the exposure of children to this violence. So this detection and early detection intervention is an important uh, activity that the health sector can play. But we know that unfortunately, these meetings many times are wasted opportunities. And even worse, in some cases, it may re-victimize women and perpetuate these gender inequalities and the impotence feelings that women experience. So the report of the Lancet Commission is an important contribution. We want to transform services. We want that these health services are centered on the needs of survivors and that they respond to their needs. The report mentions the co-production of services, and it's important, especially to start to transform the social attitudes. This is still a topic that is difficult to recognize or highlight. And many times women in our settings are receive answers like maybe you did something to provoke him or marriage is like that. So health providers, in order to provide a service, have an important role to play at the community level in transforming the attitudes and contribute to these cultural changes. I'm going to cut short so we have time for discussion. The report of the Commission emphasizes the role, the significant role of health services and providers. The importance of transforming has already been mentioned, to have a trauma approach, understanding the role of violence. And it is important because we continue training health providers, including psychiatrists and mental health providers, that graduate without learning or heard much about this topic. And we would like to start to transform the providers and the services so they can contribute to the rehabilitation and recovery and healing of survivors. And as had already been mentioned, this also requires dismantling the gender inequality and other inequalities, promote equity and other inequalities that contribute to violence. There is a framework adopted by many of the UN agencies and some financiers of programs to prevent. I'm not going to go into detail, but it identifies the areas where we have some evidence of promising practices that have shown some efficacy to prevent. These are not changes that are easy to make happen, has to do with beliefs and in terms of gender, but all women and other IPV victims deserve to enjoy the right of a life without violence. And we think that this report is a contribution in this direction. I'm going to stop here to participate in the. Thank you. Thank you so much, Dr. Garcia Moreno, for your presentation. Give me a minute here. A second. We thank you again, and we should point out that Dr. Garcia Moreno shared with us that WHO has paid attention to the issue of prevention and response to violence against women, and despite the changes in the last 25 years on working on violence against women, including to acknowledge it as a significant factor that impacts on women's health, their children and their families, and it is a problem of public health, it still requires an urgent response, as has been mentioned by our previous speakers, highlighted by Dr. Montero. She also pointed out that WHO pays special priority to mental health. And WHO has a slogan that there's no health without mental health. She mentioned that the Lancet Commission report emphasizes the important role and responsibilities that health and services and providers have, but also on mental health in particular, and to respond to the violence survivors. He highlighted it's extremely important to have services that receive women and other survivors with available services of good quality, because they're still limited. Dr. Garcia Moreno, once again, thank you so much. And we ask you to please remain in the room for starting the Q&A. I'm going to take this opportunity with the event. We would like to greet all those who are connected and have joined us from public and private institutions from several countries. First, a special greetings to all of those who are joining us from the Ministry of Health from Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. We would like to thank the mental health centers, community mental health centers that are being with us. There are many of them have joined in different areas of the country, to the public health school of the Universidad Cayetano Heredia and other institutions, well as Salud, the consultation roundtable to fight against poverty. And we would like to thank, in addition to the Andean countries, Argentina, Cuba, Honduras, UK, Mexico, Spain, Uruguay, all those persons that from those countries are joining us. After these moments of learning and knowledge exchange, it is essential to take some time to relax and start a mini physical exercise session while teleworking. Horas Conju encourages the wellness of those who join us in this virtual session. And in the next few minutes, we will exercise with an active pause to stay healthy, combat stress, reduce work fatigue, and keep muscles flexible and healthy. Please go ahead with the active pause. Thank you. There's not going to be interpretation during this active pause, Dr. Fisher. Then we come back with the Q&A.
Buenos días, buenas tardes, desde cualquier parte del mundo, donde quiera que te encuentres, bienvenidos a realizar esta actividad saludable. Así que desde el Organismo Andino de Salud, Convenio Hipólito Unanue, los invitamos a participar en esta actividad divertida. Así que vas a tomar una hojita de papel, preferiblemente reciclado porque somos amigos del planeta, y vas a realizar una pelotica de papel. Pelotica de papel, vuélvela una pelotita antiestrés. Y hoy vamos a trabajar esa liberación del estrés y la agilidad. ¿Cómo estás de agilidad? ¿Trajiste la habilidad del día de hoy? Bolivia, Chile, Colombia, Ecuador, Perú y Venezuela hoy trabajando juntos desde la agilidad para hacer esta actividad saludable. Así que nos fuimos. ¿Tienes tu pelotita antiestrés? Empiecen a lanzar, que toque el techo de donde estás. Vamos, láncela bien alto, arriba, arriba, arriba. Perfecto, domínelo. Cuando la tenga ya dominada, así que quiero que miren, lanzo, aplauso, recibo, lanzo, aplauso, recibo. Nos fuimos. Largo, grande, amplio, generoso, y no se te olvide la sonrisa. Eso es, lanzo, aplauso, recibo. ¿Qué tal si me regalas 2 aplausos? 1, 2, 1, 2, 2 aplausos, si se puede. 1, 2, domínalo. Si se puede. 3 aplausos. Perfecto. 1, 2, 3. 1, 2, 3. Si se cae la pelotica, la recoges y sigues. Vamos. 3 aplausos. Vamos a romper el récord en el Organismo Andino de Salud. ¿Cuántos aplausos eres capaz de dar? ¿Listo? Lanzo, lanzo. Cuente, cuente, cuente. ¿Quién tiene el récord? ¿Quién tiene el récord? Perfecto. 4, 5 aplausos. Los que alcance a hacer. Esa es la actitud de energía positiva. Excelente. Vamos, nos fuimos. ¿Cuántos aplausos fuiste capaz de hacer el día de hoy? El profe va como por 4 aplausos. Muy bien. Excelente. Lanza la pelotica. Con tus 2 manos te vas a tocar la cabeza. ¿Listo? Mire, lanzo, toco cabeza, agarro. Lanzo, toco cabeza. Con ambas manos. Perfecto, domínelo. Esa es la intención, esa es la actitud. Están demasiado coordinados y ágiles ustedes, así que cabeza a hombros, mire. Cabeza a hombros, agarro. Lanzo, cabeza a hombros. Coordínense. Si se puede. Agilidad. ¡Ánimo! Perfecto, necesito saber quiénes son los más coordinados del Horas Corvus. Si se puede. 3, 2, 1. Y sabe que vamos a agregarle un tercer ejercicio. Yo creo en ustedes. Vamos a hacer cabeza, hombros, aplausos. ¿Listo? Lanzas la pelotica, cabeza, hombros, aplausos. No se rinda sin intentarlo, no fuimos. Cabeza, hombros, aplausos. Si se puede. Cabeza, hombros, aplausos. Eso es. Domínenlo conmigo. Si se puede. Energía, cabeza, hombros, aplausos. No se rinda. Rendirse es para otros, no para nosotros. Esa es la actitud. La gente del Organismo Andino de Salud, la más fuerte, la más valiente. Esa es la actitud. Los que no se rinden. Eso. 3, 2, 1. Perfecto. Último, cabeza, hombros, aplausos. Agárrenlo. Muy bien, excelente. ¿Cómo estamos de coordinación y de descoordinación? ¿Vamos bien hasta ahí? Perfecto, lanzo la pelotita, voy a hacer un aplauso, pero lo voy a hacer detrás de la espalda y agarro. ¿Listo? Entonces hay que hacer ágil. Revisa tu espacio, que no te vayas a pegar con nadie. Eso es, con nada. Muy bien, lanzo, aplauso atrás y agarro. Si se puede. Lanzo, aplauso atrás, agarro. Vamos. Energía, aplauso atrás y agarro. Si se puede. Lanzo, aplauso. Perfecto, domínenlo, regálenme 10 de sus movimientos. Yo voy 5. ¿Cuántos le quedan? 4. 3, 2, perfecto, 1, energía y descanso. ¿Qué tal si hacemos aplauso adelante, aplauso atrás? ¿Listo? Sí se puede, vamos. Voy llenándonos de energía hoy. Esa es la actitud. Entonces, miren, lanzo aplauso adelante y atrás. Adelante y atrás y agarro. Adelante y atrás y agarro. Sí se puede. Vamos. Energía positiva para todos. Perfecto. Adelante y atrás y agarro. Adelante y atrás y agarro. Sí se puede. Domínenlo. Esa es la actitud, esa es la intención. Perfecto. Energía. 3, muy bien. 2, muy bien. 1, último, último. Y agarrar la pelotica. Esa es la intención, esa es la actitud. Bueno, me dicen que Bolivia, Chile, Colombia, Ecuador, Perú, Venezuela trabajan juntos desde la coordinación hoy para llevar hábitos de vida saludable. Y muy importante. No hay que rendirnos, ¿cierto? A veces parece difícil, pero no lo es si le ponemos actitud. Último ejercicio. Vamos a hacer el último. Quiero que tomes tu pelotica. Mire lo que vamos a hacer con ambas manos. La vas a acercar a tu cuerpo, vas a soltar la pelotica, le vas a dar un rodillazo. Perfecto, y la pelotica va al aire y la coges. Uy, profe, eso suena muy difícil. Realmente suena más difícil de lo que en verdad es. Usted lanza y agarra. ¿La tiene? Perfecto, mire. Perfecto, que rebote. Que no se caiga. Si se cae, la recogemos. No pasa nada. Eso es. Rebota en la rodilla y la agarras. Sí se puede. Muy bien. Cuando domines la pierna derecha, quiero que lo intentes con la pierna izquierda. ¿Listo? Sí se puede. Vamos, coordinados. Sí se puede. La otra piernita, ya. Muy bien, suelto. Perfecto. Rodillita y la agarro. Ahí les vamos dejando ese ejercicio de tarea a todas las personas del Horas Cono para que trabajen la coordinación, la agilidad. Muy bien. El dinamismo. 3. Muy bien. 2. Excelente. 1. Perfecto. Y descanse. Muy bien. Excelente. ¿Cómo nos ha ido el día de hoy? Como siempre, un estiramiento para liberar las tensiones de nuestro cuerpo, llenarnos de energía. Quiero que cojas la pelotita con ambas manos. Perfecto. Sube los brazos todo lo que puedas. Separa las piernas. Estírate, estírate arriba. Eso es. Sonrisa. Mire, nos inclinamos para un lado, estiramos la espalda. Perfecto. Liberamos estrés, tensiones acumuladas, nos llenamos de energía positiva, vuelves al centro lo más arriba que puedas, vamos para el lado contrario, eso es, y respirando siempre, respiración algo súper importante, estiro, 3, 2, 1, vuelvo al centro, tomo aire, exhalo y bajo los brazos, calorcito, energía, fuerza. Mire, hoy desde el Horas Cono les agradecemos de todo corazón haber estado con nosotros en esta pausa activa, saludable, divertida y los animamos a seguir haciendo ejercicio de forma activa. Organismo Andino de Salud, Convenio Hipólito Unanue, un abrazo a todos. Chao, chao.
Muchísimas gracias, Rob.
Thank you so much, Rob, for providing
dinámica.
support for this dynamic. Start a dialogue based on the questions asked by the audience. I invite the speakers to turn on their cameras. Please. We will show you the questions that we have received. Okay. We have a question for Professor Fischer. Do you have national or international progress in monitoring the prevalence and severity of IPV and other forms of violence and their associated factors? What would be the most important indicators to measure and what standardization opportunities do we have? So please go ahead, Dr. Fischer or Professor Fischer.
Sure, that's an excellent question. In terms of progress, I think I'll pass to Claudia in a second to talk about what the World Health Organization have been doing, because they've done a lot of work in that area. I think there are lots of opportunities to come together to think about what best to measure, what the best indicators are. I don't think I personally want to provide a specific answer to the indicators, because I really think those need to come from survivors of intimate partner violence themselves. I think there's a lot of work to be done in trying to understand what people who've actually experienced violence think are the most important aspects to measure. I think it's really important to bring people together to think about those. So I think there is a lot to be done. I don't know, Claudia, if you want to say anything about what's happening on the World Health Organization level.
Just to add that at global level, we have the SDGs that include in 5.2.1 and 5.2.2 under the goal of eliminating violence against women and children. There's an indicator that measures the prevalence by IPV in terms of physical, sexual, and there's another indicator that measures sexual violence by other perpetrators that are not the IPV, the intimate partner. This is the effort that we've done with the nations trying to collect data from the countries have through Endesa survey that you have in Peru and other national surveys. What we have done is to have a database that are not generated by us. They come from the countries to carry out a global analysis into the regional and local estimations for these two indicators that are the ones that are globally measured. And Helen mentioned at the level of the programs, we need more pragmatic and concrete indicators that will really capture what women and survivors see as significant or important. Thank you very much, both of you, Professor Helen Fisher and Dr. Garcia Moreno. I'm going to ask a question for Dr. Marta Rondon. What guarantees are given by the Peruvian state to the girl or woman who is a victim of violence to go against the perpetrator, given that the most of the violence is produced in the home? Please go to the Spanish channel. Go ahead with your answer.
Sí, sí estoy en el canal de español.
Le escuchamos bien.
Sí. Es una pregunta muy compleja.
It's a very complex question because it's difference between what the law states and what happens in reality. If you read the law for the eradication of violence and the important document, the protocol of joint action between the Ministry of Health and others, there is they speak about coordination, taking the story only once, as soon as possible, by the Gesell camera chamber, and not, I've been asking again the girl and now re-victimize her. And there's a guarantee of confidentiality and privacy. But in reality, the people do not, the different institutions don't exchange the information as they should. So the girl and the family are asking the same, and then in the health service, and once again, they have to report this in the police station and then legal medical exam. We are doing some efforts from the Ministry of Health in order that we can guarantee that the medical exams of hospitals are well done and have all the important characteristics to have a forensic value, and that there is no need for the girl to go to the legal medical service of the communities, and we're still working on that. So there's some laws and guidelines that protect, and a pragmatic practice that actually makes this slow and re-victimizes. Thank you, Dr. Rondon, for your response. Now a question for Dr. Garcia Moreno. Do we know of local experience in change of social standards that accept the violent behaviors? What can we learn from these? There are several promising experiences, and I invite you to go to the web page of the implementation package for respect. The document that I show that synthesizes the evidence, because there you can find examples of specific programs that demonstrate some efficacy. Have some programs that work with group of men and group of women separately and then together around the gender standards. We have school programs where we are working on sexuality, gender equality, relationships, consent, etc., that have shown being effective. So we have examples, but in general, we are at a moment where we have some evidence, but these are from small programs implemented at a lower scale by NGOs. And what we need is to take those examples and see what can be done at a bigger scale. I believe that schools offer an important opportunity where we can work many of these topics. And we need to start because schools need to be safe places. We still have situations where teachers abuse the children, and there's a lot of mutual violence among students. So there's a lot of things to be done at school, and there are promising examples in several countries, especially at the community level. Thank you, Dr. Garcia Moreno, for your response. I have another question for Professor Fisher. What basic requirements should mental health services comply from at the different levels of care in order to avoid victimization and to provide one timely response in cases of partners violence? Should we have to specify specific according to the life cycle? Thank you, Dr. Fisher.
Thank you. That's a really important question. I'm going to refer to Claudia again in a minute because she can tell you hopefully about the lives principles that the World Health Organization have put together, which are really important to follow. But I think for mental health services, the really key thing is that practitioners need to be trained. They need to understand how to listen, how to respond to disclosures of violence, but they need to first be able to ask. They need to create a safe space when that person comes, whether that be a man or a woman or a child. They need to be able to create a safe space for that person and ask them about their experiences of violence, including intimate partner violence, as well as what else is happening in their lives. And they need to be able to be empathetic about that, not to be judgmental, but to listen really sensitively to that and help that person to think about how they can get some support and help with what they're experiencing. So really important that the practitioner has training in that space, but also that they actually have, if you like, they're plugged into a network where they can refer on often to more specialist services, and those might well be in the community, in non-governmental organizations rather than within a mental health care setting. But they need to know where can they then help that person to get more specialist support from, and that needs to be kind of worked out before they're asking the question. But they need to ask, which people really don't do very much at this point. They need to really sit and listen and behave sensitively to that information, and then think, what does that person need at this point, and really discuss with them how they can get that help. I don't know, Claudia, if you want to add anything about the lives principles or other aspects.
Quiero mencionar tres cosas. Uno es que
three things that WHO, in addition, that does specialized mental health services, but we know that many countries, especially in poor areas, they're very limited or inexistent. So another axis of the effort of WHO in mental health is that primary healthcare providers be better trained of what they are at present in being able to respond to a large part of mental health problems. There's severe mental health problems that require specialists and psychiatric treatment, but a large amount of mental health problems like depression, anxiety, post-traumatic stress may be managed at the primary level if people are adequately trained. There is a large problem called MHCAP. I don't know the exact translation to Spanish, that is promoting training of primary healthcare providers. The second thing is that, as Helen mentioned, is actually sensitize the providers, improve their communication skills with many basic things of how you speak, how you listen, how you sit, what message are you given when people are disclosing or telling you something important, and that may necessarily that they need a response at that moment. Physicians usually think that we need to solve everything. And many times it's not a problem that necessarily we're going to solve, but women, just by being heard with empathy, without being judgmental, and that we validate that it's not their fault, that they're not alone, that this is something that happens and it's not her responsibility only. Many times with this, that allows women to start becoming aware of the situation, make decisions. Of course, as Dr. Rondon mentioned, there are women that will need more specialized care and specialized services, but a large portion of women, what they need is somebody to listen to them with empathy, with respect, validate the situation, and refer to practical service.
Adelante, doctora Rondón.
Go ahead, Dr. Rondon.
Muchas gracias.
Thank you.
En la línea que ha dicho la doctora García Moreno,
What Dr. Garcia Moreno mentioned, I think it's important to remember that there's a publication from WHO with a clinical handbook for to deal with violence from 2014. And there they explain step by step what do they mean, for example, to listen with attention, how you have to respond, and how do you validate a women's experience, what you need to tell her, and how you take care of your body language. These are basic things that can do a real change on how we are caring in this initial care for women, where we can capture and they are able to tell us about their experience of violence in the primary level or any other level, because these are significant skills to have throughout the entire context with a woman that has been subject to violence. And then I would also like to insist that violence, especially when it occurs in early ages up to adolescent, produces a trauma, and that trauma is going to make that if there any mental disease as a consequence of that early violence, these mental diseases are going to be complex, have comorbidities associated, and be difficult to treat. That is why it's so important that we start building specialized services for those women who have more complex needs and perhaps are not the majority, but it is important to offer what they need. Thank you, Dr. Rondon, Dr. Garcia Moreno, and Dr. Fisher for your response. I have a question for Dr. Marta Rondon. What care should we offer to the offsprings of feminicide victims? Thank you. That is an extremely important question, because these children are going to be affected by an early trauma. And therefore, we should do every effort possible so they can go into a protective environment and receive the type of treatment and educational experience that would allow them to minimize the repercussion of this early trauma. The early trauma is related not only with an increase in mental disorders, but also with an increase in the risk of chronic diseases such as diabetes or hypertension. And we think that if this is just the space for depression and anxiety, but it's also related with an early start as an expression of schizophrenic disorders and bipolar disorder that if they didn't have that trauma would not have manifested. There's a lot of literature in that regard. So the boys and girls who come from a feminicide experience be carefully evaluated and have to live in a family that will receive counseling and periodical interventions that will allow them to deal with the behavior changes that they surely going to show without having them undergo into new violence experiences. Thank you. Thank you. Very interesting answer to the questions that the audience has sent us. Dr. Garcia Moreno, they ask us, how can you involve the civil society in the prevention and response to cases of family violence? Well, many of the attention at this moment and for many years have been offered to civil society through NGOs, especially women's organizations and feminist organizations, which are the ones that for many years have put these topics in the agenda. So they are already involved. What we've seen in some countries that works adequately is the partnership between government and civil association, where we have examples where there are NGOs that are counseling the government hospital. Like in India, we have other examples where we have specialized centers that have government support, but are administered and the services are offered by NGOs. So there are several models of partnership between civil society institutions and national or state institutions that work adequately. And I think that this is a way that they can mutually benefit from the experience, because the NGOs have large experience with these services and know what women want and are part of the co-production of these services to involve civil society in these discussions, in research, and to start having more co-participation. Thank you very much. I have a question for all of you. Do you know of any prevention of family violence in partnership with traditional physicians or of Aboriginal people? Do you know of any experience that you would like to share? Go ahead, please. You can answer. Would you repeat the question, please? Yes, of course. They ask us if you know of any experience where they've worked these intrafamily violence with support or in partnership with traditional physicians. traditional physicians come from original people. Not necessarily traditional medicine, but midwives, for example, that can identify violence or other type of staff that is part of the traditional medicine. There are some examples, but actually I don't know them in detail. I know that in Chiapas, in Mexico, there's activity with the midwives, not only to identify violence, but also to support on maternity and other topics, training programs for traditional midwives in many countries in Africa. And specifically on violence, we know that the indigenous groups in general, for example, in Latin America, but also in Canada and Australia, the original groups have higher rates of intrafamily violence related also with historical violence and discrimination that they have suffered. So it is important there to work domestic violence in that historical context and other violence that original people suffer in many areas. I had an experience in Australia where the concern of people was domestic violence, but the concern of women and those communities was multiple other ways of violence that their children and husband had, such as unemployment, alcohol and substance abuse. So we need to contextualize domestic violence in that setting, and programs must be much specific and to involve co-production. They were clear that the programs that have worked better are those designed by people from the original groups and that involve as counselors and social workers to people from those original groups and not people that come from outside. So once again, the co-production and participation of civil society and institutions that are specifically dedicated is extremely important. Nothing for them without them. Yes, we need to listen and to know them, to respect them, to know how to intervene. I would like to comment that from our institution, with support of PAHO, we are training in dialogues of knowledge, which is a communication strategy that allows people to get close to any authority or any health professional or from the health team to discuss with the original populations at their sites, in their context, and be able to do it horizontally, but also fall with respect and generating trust. Only that way we could learn about their needs, and in case to some type of intervention if required, or a joint intervention as Dr. Garcia Moreno. Would you like to add anything else, Dr. Fisher or Dr. Rondon, about this?
Just really briefly, just to echo, I think all of those points are really important. And I just wanted to go back to what Claudia mentioned earlier, which is obviously globally, mental health services are incredibly difficult to access for most people. And therefore it's a real priority to take the time and really think about how we integrate those mental health care services into primary care, but particularly in this case to strengthen the training of lay workers and really providing kind of grassroots and user-led alternatives to mental health services so that we can really prevent and reduce that exposure to intimate partner violence. And just to echo, that absolutely has to be done with the communities themselves and led by them. Thank you.
Muchas gracias. No sé si No sé, ¿tenemos otra intervención? No, si no paso a una siguiente pregunta. Te estamos escuchando, Jorge. A ver, acá va. ¿Se entiende?
Okay, we have another question. We understand that from the inequality situation, we prioritize women survivors in domestic violence. Could we mention about the men survivors? This is an open question to you three.
Maybe I just quickly add, I absolutely agree. I think it is a gendered problem. It occurs more commonly to women and girls, but absolutely there are many millions of male survivors who experience intimate partner violence, either from other men or from women across the world. And they are really, really important. And I've mentioned previously, particularly amongst men who have mental health problems. Certainly research in a UK context shows that a third of those men who are in contact with mental health services have experienced themselves intimate partner violence. So it is a really important group to also look at. We definitely don't want to exclude them. We need to think about how they access services, and often they face different barriers to women. Often they find it harder to disclose because of masculinity norms, and so we need to think carefully about how they can access services as well. I don't know, Claudia or Marta, if you want to.
Muchas gracias. ¿Quisieran agregar algo, doctora Rondón?
Thank you so much, Dr. Rondon. Dr. Garcia Moreno, would you like to add anything?
Doctora Rondón, adelante.
Doctora Rondon, go ahead. It is true that there are men affected by violence, and we have focused in the elderly, in people who have disabilities, people who live with mental disorders, and those who are sexual minorities. And that leads us to observe that gender violence is a phenomenon that affects who is perceived as belonging to a group with less power, either because it's ill, has a disability, or because socially is discriminated or is in the dominated gender. However, it's still majority problem that affects women. And for men who survive violence, it is very difficult because the stigma and masculinity mandates don't allow them to look for help on a timely basis. That is an issue that we need to work around. Thank you. Okay. We thank you for excellent speakers, for your answers. We thank for all the questions. We were not able to respond all of them, but we will consider them to define the topics of the next webinars. We appreciate your participation and interest of all the audience. To close this space, I ask the speakers in 1 minute, leave us a clear message on this topic for the entire audience. Go ahead in the order of the presentations, please. Professor Fisher, Dr. Rondon, and Dr. Garcia Moreno. Go ahead.
Thank you. So intimate partner violence is a public mental health problem that has been marginalized for too long and needs to be addressed so that women, men, and their children are not exposed to intimate partner violence. I've said that evidence points to several targets for prevention and intervention in individuals, families, and communities and societies. And with coordinated action, scientific effort, and political will, there is not only opportunity for change, but an imperative to do so. So I really strongly implore you to join us to fight and work out how to stop intimate partner violence.
Adelante, doctora Rondón.
Go ahead, Dr. Rondon.
Bueno, la
Well,
violencia contra las mujeres
violence against women
de la inequidad
is a
de género.
daughter of gender inequality.
Entonces,
So
tenemos que transformar
we
nuestras
have
sociedades
to
para que
transform
sean
our
sociedades
societies to make them
equitativas,
more
donde
equitable
la
societies
igualdad puede ser
where
ejercida
citizenship
por igual por
can
hombres
be
y mujeres.
exercised the
Y
same by men and
el
women,
reparto de los recursos y
where
de las
the
oportunidades
allocation of
debe
resources
ser
and opportunities
sea
and the care
equitativa
efforts should
para
be
poder
more
realmente atacar
with more
la
equity,
raíz
so we can
de la
tackle
violencia.
the root of
Mientras
violence.
tanto, además,
In the
toca
meantime, we also
encontrar maneras
have to find
para
the way to
encontrar a las personas que han sido afectadas por la
identify
violencia
people
y
affected by
ofrecerles
violence
los
and
servicios
offer
que requieren
the
para
services that they
contener
require and make
la
all the
desigualdad y la
effort
transmisión
to stop the
intergeneracional.
intergenerational transmission of violence. Thank you.
Bueno, yo voy a abogar por
I'm going to advocate for the integration of this
en los currículos de médicos,
in
enfermeras
the
y
medical
trabajadores de
nurses
salud,
and all health provider
de
curricula,
asegurarse que
and
todos
to
los
make
proveedores de
sure
salud
that
que
all
han
health providers
con
who have
gente
contact
en el día a día y en
with the
particular en los
people on a daily basis, and in particular the mental health services,
el periodo
as it has been
prenatal,
pointed in the
embarazo,
perinatal and during
momentos
pregnancy, there are moments
digamos, que pueden ser más fructíferos
that can be more fruitful in terms of early
todos
identification and early treatment.
psiquiatras, psiquiatras,
Psychiatrists,
geriatras,
gynecologists,
estar
obstetricians,
capacitados para
pediatricians should be
diagnosticar
trained
y saber
to
cómo
identify
proporcionar
and
una
know
respuesta
how to
inmediata
offer an initial
que ya
response,
hablamos lives
as
o
we already
llamadas
mentioned,
de
live anima,
y
of
referir
listening,
cuando
and to
necesario a
refer
otros
when
servicios
needed
más
to
especializados.
other more specialized services.
Bueno, muchísimas gracias.
Thank you very much. Now,
Luego de reiterarles nuestro
after
agradecimiento
thanking you
a
again,
todos los que nos
and to
acompañan
all
día
the
a día,
audience that are with us week after
muy
week,
especialmente quiero agradecer al
I
equipo
would
del
like to thank
ONU,
the
que de
Orascon
alguna manera u
team
otra nos apoyan
that support
donde
us
están.
from where they, wherever they are, and to thank
desarrollo de este webinar que
for
fue
this
posible gracias al
webinar
compromiso
possible through the
con la comunidad
commitment
andina y
with
con la integración
Andean
de nuestros países.
integration and Latin America
Sin más,
integration.
voy a darle la palabra a la doctora
Now,
María del
I
Carmen
will
Calle,
give the floor to
presidenta
Dr.
de la
Mariel
Asociación
Carmen Calle
Andina
to
de
close
Médicos
this
Enfermeros
webinar
y
on behalf
Trabajadores de Salud.
of the Andean Health
Adelante,
Organization y
doctora Calle,
Policy
por favor.
Nane Agreement. Go ahead, Dr.
I
Calle.
would like to say that this was a fantastic webinar. Fantastic. Why? Ahora me voy a castellano.
Now I'll go into switch into Spanish.
Muchísimas gracias.
Thank you so much, Helen, Claudia, Marta. Thank you so much. This is a topic that's not over yet. This is a very long. I'm a pediatrician, and I entered in contact with this issue 20 years ago when I was doing my doctorate 20 years ago in public health, my PhD in public health, and I became interested in this topic 20 years ago. So I have participated in almost everything, and truthfully, I still believe that there's still much to be done. And there are several topics that I would like to remind you. First one is that this is a public health problem. The numbers are horrible. 1 out of 3. At the beginnings of 2000, there was a study in 10 countries where Peru was one of them, and we had one of the highest indexes. When we look at the world map, we realize that we're still among the highest. And the countries from the Andean region in Latin America, with some exceptions, are among the highest. Another very important point is that it starts very early. This violence starts very early when we talk about IPV. We're talking about violence when they're falling in love. And here I would like to acknowledge that there's a very interesting guideline in Peru about becoming in love, and how from these relationships from the very start have to do with violence. And we should not forget that when we talk about violence, we talk about difference in power. We're talking about a situation of power, and one that has more power over the other one. That is why I think that it is extremely important to provide an ecological approach to this issue. Policies are not sufficient. The cultural change is not enough. There are several things that happen at the same time. So from the empowerment of girls, so in vogue now to empower girls from the very early ages up to have policies with budget, as Marta mentioned, because we always say without budget, there's no rights. Because I don't have there's no use in having a policy that has the money to make it real. But we need to talk about several levels. First, home, household, the family. The family is actually a protective entity. We realized during this pandemic the increase in violence because they were confined in their homes, suffering the largest stress that humankind has had in recent years. Because we also need to recognize the context in recent years. This is the third year of pandemic. This is a context that has changed many things and has increased the violence topics. I'm talking not only of the IPV, but also the violence through the life cycle, especially against girls and adolescents. Another topic that I think is very important, which was mentioned by Claudia, is to add this topic in the pre-graduate levels. I started reviewing the curricula. We continue giving priority to physical health in the curricula of the health professions, mostly in the medical profession, because you realize the importance that you give to someone by the number of hours that you dedicate to study. It's as easy as that in pre-graduate level, everything is physical health and little mental health. And at this moment, we have an emergency in mental health. And if we don't recognize it, it's because we don't want to do it. The global health emergency is a syndemic. In the similar way as the COVID-19 and the monkeypox pandemic, that is affecting, and the studies are very clear that it's affecting our small babies, because there are well-done studies that they mention of delay in development. So there are many things to be said. And I think that it is very important to have this rich document. I invite everyone to read it. We have discussed here is just a small example. Don't forget to read the report of mental health from WHO published this year. There are basic documents there. And I would also like to remember what are the characteristics that these strategies should have. This famous respect to prevent violence against women. It's very clear that it's not just health services involved. We are talking about relationship with women empowerment, guarantee of services, reduction of poverty, safe environment, preventive efforts for abuse of children and adolescents, need change of attitude, beliefs, and norms. Our laws may say many things, but our social standards are the ones who mandate our population. I really like the fact that they mention all the vulnerable populations which are a special interest of our institution. And also to close, many times you said, many times you repeated, it's been a word repeated quite a lot in the characteristics that the health worker, first of all, they need to know about the topic, of course. We updated in that topic, but as important as their knowledges is the attitude of respect, to have empathy, not stigmatize, not judgmental, not allow that this person that has suffered violence undergoes another type of violence. I think that is. I share with what the Lancet Psychiatry has mentioned, that our mission is to prevent this activity, and so we can decrease the prevalence of mental health issues in obviously with a scientific effort in coordinated action and definitely political will. It's not only, it's the only opportunity to change. Not just an opportunity, but it's imperative. I firmly believe in that. I believe in what has been said. It is extremely important. Ecological approach, political relationship, family, school, community, civil society, strategic partnership, a large chapeau of policy that will favor. But I fully convinced that if we don't achieve equality, we're not going to achieve the decrease in this problem. I'm fully convinced that we need to achieve gender equality, and we need to aim opportunities, men and women, of having a life in our life. As I always say, it's worth living it that we have done. Thank you so much, Helen. Thank you so much, Marta. Thank you so much, Claudia. It's been a webinar that I'm sure that is going to be not only this one, but it's going to be the beginning of more partnerships of you with us in the Andean Health Organization, Hipólito in Unano Agreement. I would like to thank all the people from the Andean Health Organization, Gloria, Marisela, Milagros, Yadira, Rob, and all the people from the Andean Health Organization that make it possible that these webinars. We invite you to webinar on Tuesday. Tuesday? Yes, I think it's Tuesday. We're going to talk about breastfeeding, which is so important. Thank you very much. We had more than 500 people that have joined this webinar, so we hope that all the knowledge and updated acquired will serve, so for each day we can do a better job. Thank you very much. Good afternoon.